ladies and gentlemen. Delighted this afternoon to introduce Dr. Shayna Sarosiek. She is a clinician at Dana-Farber and is a friend to many in this room, and a doctor and a supporter and a great friend of the IWMF. So, Dr. Sarosiek?
So my task today was talking a little bit about Waldenstrom's complications, and hopefully this will be informative to you all. But I'm really happy to be here and honored to be asked to give this talk. I think the IWMF has been life-changing for so many of my patients, and hopefully I can contribute a little bit to the understanding of Waldenstrom. So this will not in any way be an incredibly pull it down a little bit. Is this better? Okay. Tell me if I need to change anything else. So hopefully this will at least just give a brief introduction to some of the complications that can happen with Waldenstrom's. It is in no way meant to be scary because these are almost all rare complications of Waldenstrom's. So it's not something you should all expect to have all of these symptoms, but hopefully you can just be aware so that there are things you can watch out for or ask your doctors about. So this first slide is really just to give an idea of the different presentations of Waldenstrom's. I was just talking to some patients at lunch, and we were talking about how, although this is one disease, I just see one disease, it's as if every patient has a different disease because the presentation can be so different. Some patients, and a lot of patients, as you can see in the top middle of this slide, you can see that a lot of patients present with low blood counts. So they have anemia or they have low platelets. But some of these other things, as you go around the circle, are much less common. As we move clockwise, you can see that some patients have hyperviscosity. So I'll talk about that, but that's a thickening of the blood. Some patients at the next arrow have complications of the IgM itself. So the IgM antibody that's made from the cancer cells can cause specific symptoms. And then other patients might have low iron. That's quite common and maybe more common than people recognize sometimes with Waldenstrom's. And then some other things might be less common. So Bing-Neel, or cancer cells within the area around the brain or the spine, that only happens about 1% of the time. And some of these other things like kidney or lung involvement are also quite rare. But I'll try to focus in on some of the most important things that I think you should be aware of in case these develop for you or your loved ones. So first I'll talk about hyperviscosity because this gets a lot of attention with Waldenstrom's. And what hyperviscosity is increased thickness of the blood. So essentially, patients have an excess of IgM or more IgM that should be in the bloodstream, and it makes the blood more viscous or more resistant to flowing through the blood vessels. It's important to know that you can have a little bit or mild hyperviscosity without symptoms. That's very common and not something that needs to be urgently treated. But if the hyperviscosity becomes symptomatic, that's when you need to intervene. The risk of having symptoms from hyperviscosity generally starts above a level of 3,000, but is still uncommon until you get closer to the level of about 6,000. At our institution, we tend to use just the IgM level to help us gauge a patient's risk of hyperviscosity. But some institutions use also the serum viscosity, so a blood test that will actually check what the viscosity of the blood is. When we worry about symptoms developing because of hyperviscosity, we think about a level being greater than 4. So often patients will come to me and say, I was told I need to start treatment because my viscosity is 2.4 or 2.5. And although that's out of the normal range and the blood is a little bit thicker, that's not a level that generally causes issues. So we wait until the viscosity gets a little bit higher because many patients can live with a little bit of increased viscosity with no symptoms or problems for a long time. So the reason that Waldenstrom's often leads to hyperviscosity is because of the antibody itself. So you'll see this little antibody multiple times in this presentation. But antibodies are this Y-shaped protein that you can see that blue and red figure there. There are different types of antibodies. that have different jobs in the body in terms of fighting off infections. But the IgM antibody is in that shape like all the other antibodies, but it usually travels in this group of 5, what we call a pentamer. And because it groups together like that, patients are at increased risk for their blood being thicker because it's there. So patients who have high IgG or IgA or other antibodies aren't at high risk for hyperviscosity. It's because the IgM travels in that group that patients with Waldenstroms are at increased risk. And this figure here, I'll take a second to explain it, is something to give you an idea about the risk of having symptomatic hyperviscosity. So if you look at the numbers at the bottom, these are done in, depending on what units you use, whether you use, we typically use milligrams per deciliter, but this is in grams per liter. But if you look at the bottom, 0 to 10 would be what most of us think is 0 to 1,000. 10 to 20 is 1,000 to 2,000, et cetera. But if you see it's all blue at the levels from 0 to 3,000, that means that patients at those levels typically do not develop hyperviscosity. Once you reach the level of 3 to 4,000, you can see that there is a small risk that maybe up to about 5% of people might have hyperviscosity. So it can happen, but really uncommon. As you move up with the IgM to 4 to 5,000, 5 to 6,000, that increases a little bit more and a little more. But once you hit 6,000, that's the point where more than half of patients will actually have symptoms from hyperviscosity. So the level is about almost 70% of patients will have symptomatic hyperviscosity when the IgM reaches 6,000. So that's why in the guidelines for Waldenstroms, the guidelines say that you should treat if patients are symptomatic, or you can consider treatment if patients reach an IgM above 6,000, and it's because that risk of hyperviscosity is so high. So I will mention this later when I come to the topic on cryoglobulins, but sometimes patients who have cryoglobulins can have hyperviscosity at lower IgM levels, but I'll come back to that. So in terms of the symptoms of hyperviscosity, a lot of my patients wonder, am I going to have a blood clot? Is that what's going to happen when I have hyperviscosity? Or that's what I was told, and I was told to take a blood thinner because my blood is thickened. But it's actually a little bit different than that. So when we think about hyperviscosity, the most common thing that we see is mucosal bleeding. So the gums or the nose might have bleeding. And the reason for that is because the small blood vessels that are in your gums or lining your nose, as the thick blood tries to squeeze through those tiny blood vessels, the blood vessels can rupture and can bleed. So we actually think a little bit more about bleeding when patients have very high IgM than we think about clotting. The other thing that can happen is vision changes. So you can see a picture there of someone's retina, so the tiny blood vessels on the back of the eye. In this picture, you can see they're very smooth and thin vessels. But as someone's IgM gets very high, those blood vessels can rupture. You can see areas where there's just bleeding there. And you can see the blood vessels are no longer just very thin, smooth lines. The blood vessels can have this sausaging effect where they just kind of get a little bloated and they're no longer these smooth vessels. So the top things that I think about with hyperviscosity are unusual bleeding, particularly nosebleeds, or vision changes or bleeding in the retina. So when you have a high IgM, a routine exam of your retina is important. Some patients can develop neurologic symptoms like dizziness, lightheadedness, changes in thinking or fogginess. That can happen, although I have to say it's quite uncommon. And some patients report shortness of breath. When it comes to symptomatic hyperviscosity, like if I meet a patient that has vision changes because the blood is thickened and they have bleeding in the retina, that's something we treat urgently. And we do that by using plasmapheresis. So essentially a patient goes in and they have their blood kind of filtered. So the blood comes out of the body, the IgM is filtered out, and the blood is returned to the body. And that's a temporary fix. So it can get the IgM down, but then you have to do something to keep the IgM down because you haven't gotten rid of what's making the IgM. You're just temporarily making it safer for the patient and treating their symptoms. So we do pheresis for sure in this setting, but we always do it in hand with some other therapy to help prevent the IgM from coming back up and causing symptoms. Something else that contributes to bleeding that we see when patients have a very high IgM is called acquired von Willebrand syndrome. So some of you may not have heard about von Willebrand syndrome or von Willebrand factor at all, so I'll take a minute to just explain it. But von Willebrand syndrome or von Willebrand disease, typically, the way it's seen in most people in the general population is it's actually the most common bleeding disorder that's inherited. So a lot of people will have this in the general population. But in Waldenstrom's, you can acquire it. It means it can develop later in your life when your IgM is high. So what happens is patients have an increased risk of bleeding if they develop acquired von Willebrand syndrome. So sometimes, let's say I meet a patient, the IgM is 8,000 or 9,000, I worry about bleeding because of the hyperviscosity that can rupture their small blood vessels, and I worry about it because of this potential for acquired von Willebrand syndrome. So a little lesson about what von Willebrand is. So in this drawing, you see the purple, unusual shaped figures there. Those are platelets. And then the red little strings you see are von Willebrand factor. So when you cut yourself, or there's an injury, like at the bottom of this picture, a blood vessel is cut, or there's an injury from surgery or a fall or anything like that, your platelets usually all go to that area, and then the platelets are what prevent you from bleeding further. But for the platelets to stay in place and continue to work and allow the bleeding to not come back, you need that von Willebrand factor, those little red strings, to come in and hold the platelets together and kind of form a bridge to keep that clot in place so the bleeding doesn't continue. But what happens when you have Waldenstrom's is that the IgM antibody, or other things we'll talk about, can interfere with the von Willebrand factor and maybe block it from being activated or block it from getting to the platelets, so patients can have increased bleeding because of that. So these are just some of the things that are, the hypotheses about why patients get acquired von Willebrand syndrome, but it's thought that maybe, as I mentioned, the IgM itself might interfere with that von Willebrand and prevent it from being activated or getting to the platelets. Some data says that maybe the hyperviscosity, so the thickened blood in general, that can destroy the von Willebrand factor. And then some people, there's some data that maybe the cancer cells themselves, sequester or pull in the von Willebrand factor so it's not available to be used by the platelets. So there are different ways it might happen, but if the von Willebrand factor, that little red string in the picture, is not available, then patients can have an increased bleeding risk. This is more likely to happen when you have a very high IgM. I think generally, when I talk to patients, I tell them if their IgM is below 4,000, we don't have high concern about that. Above 4,000, we think about it. And I typically tell people that if they have a level above 4,000 in their IgM and they're going to have a procedure, they should be checked for von Willebrand syndrome just to make sure they're not at increased risk of bleeding. Because of the patients with a CXCR4 mutation, those patients are at higher risk for having an IgM that's a bit higher than other people. And so those patients are at more of a risk of developing acquired von Willebrand syndrome. If you have acquired von Willebrand syndrome and you're not having any bleeding or complications because of it, it doesn't mean that you need treatment for your Waldenstrom's, but it does mean that you just need to maybe take precautions if you're going to have a procedure. So sometimes we use something called DDAVP, or maybe we give different factors, like we give von Willebrand factor, or we give factor VIII. So those are things that might support you during the procedure to help that clot stay in place. But it doesn't necessarily mean your Waldenstrom's has to be treated. We just might need to support you a little bit better during a procedure. We do think, though, that typically the von Willebrand syndrome will resolve, though, when your IgM comes down. So I have many patients, they've had von Willebrand syndrome for years because their IgM is in the 4,000, 5,000, 6,000 range. And when we treat their Waldenstrom's, the von Willebrand factor levels, there's a whole panel of levels we check, they return to normal. So that's the expectation. So it's not, in the absence of any bleeding, it's not an emergency to treat just because it's there. It's just important to know it's there so you can act on it appropriately. So now I'm going to switch paths from talking about any bleeding risk. and talk about another complication that's not very common in Waldenstrom's, but I think important to be aware of, and that's called amyloidosis. Amyloidosis happens, not to many patients, but, depending on the numbers you look at, somewhere maybe around 5% of patients with Waldenstrom's. And I'm going to start just by talking about what is amyloid in general, because sometimes people think about this and they've heard this word associated with Alzheimer's or other things like that, and so I just want to explain what it is and the difference in Waldenstrom's. So what amyloid is amyloid, that term, amyloidosis, refers to when someone has a protein in the body, can be lots of different proteins, but it misfolds and then starts to build up in the body. So for example, in this picture, you see a protein that's an L shape. And naturally, that protein should be an L shape in the body. But for some reason, it misfolds, in this case, into that little U shape. And then that gives it the ability to build up within the body or within the organs. So it builds up together, forms these fibrils that then get stuck in the organs, and so you can have organ dysfunction. But it's really important to know, again, that there are different types of amyloid. So that underlying protein that's in that picture, that L shape, can come from a lot of different places. And so if you have amyloid, it's important to know, is that protein coming from the Waldenstrom's, or is it something completely unrelated? Like, for example, Alzheimer's has a different type of protein that can misfold and lead to changes in cognition, but has nothing to do with Waldenstrom's. It's a different type of protein, a different process, but the word amyloid is referred to that because it is a protein that's misfolding. But if amyloid is suspected, we recommend doing a biopsy to check and see if there's a misfolded protein, and then sending that biopsy to verify which protein it is. So that is a crucial part of the diagnosis. I'm going to mention one type of amyloid that is not directly coming from Waldenstrom's, but I think it's important for people to know about because I have quite a few patients that have Waldenstrom's and then they have this other type of amyloid, which is actually not directly related at all. It just happens because this other type of amyloid, called wild-type transthyretin, or TTR amyloid, is more common in older Caucasian males, which often is a population of people that have Waldenstrom's. So if your doctor is wondering, do you have amyloid? This is one type that could develop for you. Mostly this type of amyloid, called TTR amyloid, affects the heart and sometimes can affect the nerves, like carpal tunnel syndrome or neuropathy. This type of amyloid, though, comes from the liver. So it's a normal protein that's produced in the liver, but for some reason that protein misfolds, builds up in fibrils, and then deposits in the organs. So there are many other types, which I won't go into, just to stay simple, but I just wanted to mention that type because it can occur concurrently with Waldenstrom's. I think the more relevant and important type of amyloid for you to know about is IgM, or Waldenstrom-related amyloidosis. So I come back to this picture again of an antibody. So antibodies are this Y shape. The red portion of this Y shape is the heavy chain, or the IgM. The small blue portion is what's called the light chain. So I'm sure many of you have seen in your lab results that often the light chains are up at the same time the IgM is up. But they're part of this same antibody. If this antibody, if only the blue part is misfolding, breaking off, misfolding, building in organs, then that's called light chain amyloid, or AL. If it's the red part, the heavy chain, that's building up in the organs, that's called AH amyloid, or heavy chain amyloid. And some people have a combination, which would be AHL. So both pieces of the antibody are building up. So here's kind of a depiction of an example of what light chain would be. So light chain amyloid, that little blue piece is breaking off, it's misfolding into different pieces, it forms into these fibrils, and then it gets stuck in the organs. When patients have organ damage from amyloidosis, it can affect many different organs. So very important to know if you have amyloidosis so that we know what organs to be watching and what organs to be protecting. It can affect any. The most common I've highlighted here just in the boxes. So kidney injury by Waldenstrom's related amyloid can happen, the nervous system, and lung and lymph nodes are many patients that have lymph nodes that grow, and it's not because of the Waldenstroms only. It's sometimes because amyloid is depositing in those lymph nodes. So I'll talk a little bit about these different organs so that you can have an idea of what key things to think about if your doctors are worried about amyloid or symptoms for you to watch out for. So when it comes to the kidneys, as the amyloid or this parts of that antibody are building up in the kidneys, the kidney loses its ability to keep the healthy protein in the bloodstream. So as the blood filters through the kidney starts to let the healthy protein out into the urine. Healthy protein in general that I'm referring to is called albumin. So patients will notice that they have protein or albumin in their urine, and that sometimes it actually can make the urine look foamy or have a lot of bubbles. And then we'll notice in the blood levels that the albumin or the healthy protein level is dropping. So those are some classic findings we see when the kidneys are affected by amyloid. And when that happens, when you're losing healthy protein from your bloodstream, it ultimately can lead to significant swelling in the legs. So if someone has leg swelling, if we see their albumin level going down, this is something that I always, am on high alert to check and see if it looks concerning for amyloidosis. The other organ system to think about is the nervous system. It is commonly affected in Waldenstrom's-related amyloid. And just a disclaimer about this, many patients with Waldenstrom's can have a lot of these symptoms related to other things. So you can have neuropathy in Waldenstrom's. It doesn't necessarily mean you have amyloid. You can have changes in bladder or bowel function related to other health issues, not related to amyloid. So just because you might have some of these symptoms doesn't mean for sure you have amyloid, but these are things that might be associated. So when we think about nervous system dysfunction from amyloid, the key thing, there are two systems. So one is the peripheral nerves, which you'll hear a lot about, I think in the next talk is about neuropathy. But the peripheral nervous system is those nerves that kind of go out to the ends of the fingers and the toes, and damage to those nerves can cause patients to have symptoms like numbness, tingling, burning. I'm sure a lot of patients in this room have experienced that. So amyloid can cause damage to that nervous system, but it can also cause damage to what we call the autonomic nervous system. So that's the internal nervous system, the one that controls the functions we don't usually think about, that should be regulated on its own, like our blood pressure or how our bowels are moving or how our bladder is functioning. So that internal nervous system can also be affected. So patients might have what we call orthostatic hypotension. So they might not be able to keep their blood pressure up anymore. It might constantly be dropping. Or they might have severe changes to bad diarrhea or bad constipation. That's a new thing for them. So any of these things, change in the bowels, the bladder, erectile dysfunction. Again, they might have other unrelated causes to Waldenstrom's, but we like to think about amyloidosis if those symptoms are there. And I think that the other thing I'll note is that it's really uncommon to have only nervous system symptoms in amyloid. Typically, it does come with damage to other organs too. So that's sometimes another way that we think, like if a patient presents with only bladder changes and they don't have any signs of amyloid affecting any other organ, it's really unlikely it will be amyloid because it's really rare to have just nervous system affected, the autonomic nervous system particularly, without other signs of amyloid. So the heart can also be affected by amyloidosis. And patients, when their heart is affected, can have heart failure symptoms. So that can mean leg swelling or shortness of breath, either with activity or when you lay flat at night. So typical heart failure symptoms can occur. And we have different ways to check for amyloid in the heart. One thing that I sometimes do is just a screening, a general check, if I'm suspecting amyloid in the heart, is to check what we call the cardiac enzymes. So some blood tests that tell us, is there ongoing damage to the heart? So examples of two of those are listed there, NT, proBNP, and troponin. So those can be abnormal if there's ongoing damage to the heart from amyloid building up in the heart muscle. The other thing that we often do will be an echo or heart ultrasound, and that can show us if the heart muscle is getting thicker. Because if all that abnormal protein is building up in the heart, you can see the walls of the heart getting thicker. So that's another thing. And then a heart MRI is actually quite a sensitive or a good way of picking up if there's amyloid in the heart. So when it comes to amyloid-related treatment, so a lot of my patients will ask, well, you're treating the Waldenstroms, what are you doing for my amyloid? Or, okay, that's the treatment you just told me about is for my amyloid, but what are you doing for my Waldenstroms? And so I'd like to take a second just to explain that it's kind of on a, it's all related. So in this picture, you can see, for example, those little round cells would be the abnormal cells in the bone marrow. Those are the Waldenstroms, the cancer cells. And those cancer cells are making the antibody that then misfolds and builds in the organs. So if we're treating your Waldenstroms, that's treatment for the amyloid, because if we get rid of those cancer cells, they're not making the excess antibody and they're not causing amyloid damage. So treatment for the diseases are, overlapping. They're one and the same, with the ultimate goal of getting rid of the cancer cells that are making the IgM antibody. And then you can prevent buildup of amyloid and you can allow those organs to heal. Often, the symptoms from amyloid, like heart dysfunction, kidney dysfunction, things like that, if we get the Waldenstroms and therefore the amyloid under good control, those symptoms often reverse. And so our goal with amyloid-related treatment and taking care of the Waldenstroms is to get deep control to really get that IgM down low. We often use some of the common therapies that you all know about, rituximab bendamustine or something like that. But I will say that we don't commonly or don't like to use the BTK inhibitors, like ibrutinib or zanubrutinib are not our first choice in amyloid. Those can have some heart side effects, and if you have heart damage from amyloid, that's not ideal. So we often will kind of lean towards chemotherapies instead. And we often are a little bit more aggressive when patients have IgM-related amyloid because we really need to get the IgM as low as possible to prevent more damage to the organs. And that's not the goal for everybody with Waldenstroms. Some people have an IgM of 1,000 and they're doing perfectly well, and I'm incredibly happy at that level. But if you have amyloid, we might need to be aiming a little bit lower with the IgM, so sometimes those patients get a little bit more aggressive therapies. So the other thing that I'll talk about in regards to more aggressive therapies is the risk that patients with Waldenstroms can have transformation to DLBCL, or diffuse large B-cell lymphoma. So that's a more aggressive type of lymphoma. There are many thoughts about why patients with Waldenstroms might develop a more aggressive lymphoma, and honestly, it's not completely understood, and it's actually probably very different for each patient. But this picture is meant to show some of the hypotheses about why that happens, or where the mutation happens, or the problem begins. So you can see the very top line there in the little picture is that you have the initial cell that develops a MYD88 mutation. The patient develops Waldenstroms, and then directly from the Waldenstrom cells, you develop this more aggressive lymphoma. So that's what happens, I think, in some cases. But in other cases, you might develop that initial MYD88 mutation, and then that divides into two separate cancers. Or maybe you're someone that, unfortunately, for some reason, is prone to different lymphomas. So these two cancers develop, and they're completely unrelated to each other. So I think it can be different in different patients. And we don't always understand exactly if it came from the Waldenstroms or if it's a little bit of a separate issue, but we know this can happen. It's not really a high risk of happening, and the numbers are in this chart here, so you can see from 2 series from Dana-Farber and then a multi-institution series, that the risk of it happening is in the single digits. So in our series, 1.4% overall risk. In the other series, about 4% risk. So it's a low risk of happening, but it can happen. And the time when it happens can be different in every patient. So some patients are diagnosed with a large cell lymphoma, and then years later they're diagnosed with Waldenstroms. Some patients are diagnosed with both diseases at the same time, and some patients are diagnosed with a large cell lymphoma years after they develop Waldenstroms. And you can see that in the chart there, that on average, when that happens, it's about 4 years after the diagnosis of Waldenstrom's that someone might develop a large cell lymphoma. Patients with Waldenstroms are at higher risk of developing a large cell lymphoma if they don't have a MYD88 mutation. So we like to be pretty thorough in terms of evaluating if someone has a MYD88 mutation. One, because it can change our therapies that we use, but also because it gives us a better idea of, a risk of this happening for patients. Because we do know it's a little bit of a higher risk if you don't have a MYD88 mutation. When large cell lymphoma develops, it's usually what we call extranodal. So even though it's a lymphoma, and you would think it would be in the lymph nodes, when this happens, it's usually outside of the lymph nodes. So sometimes the bone marrow, the large cell lymphoma can grow in the bone marrow. Or it actually might grow in the bone itself, like in the hard lining of the bone, or in the testicles, or maybe a mass in the abdomen, or something like that. So it's often outside of the lymph nodes that the large cell lymphoma can develop. I typically tell patients the risk of this happening is very low, so I don't like patients to be worrying about it or thinking about it all the time. But the things that are warning signs for me is if a patient calls me and says, I have this mass that just showed up over the last week or two and it's gotten large very quickly. So a rapidly enlarging mass would be something that would, perk my ears up a little bit and make me concerned, because as we all know, generally Waldenstrom's is a pretty slowly progressing disease. So if you have a mass that's growing quickly, that might be alarming. The other thing, I've had patients that they develop large skin nodules, like a big mass on the skin, and it shows up. It wasn't there last week, and all of a sudden they have a large mass on the skin. So rapidly changing is something. Sometimes we think about this trio of symptoms, like night sweats, weight loss, and unexplained fevers. Those things can happen with Waldenstrom's, but usually when it happens with a large cell lymphoma, it's rapid onset. So many of my patients say, I have night sweats 2 or 3 nights a week. I'm drenching wet with sweat. This has been going on for years. And that's a little bit different than I used to have no night sweats, and now every single night I'm drenching wet with sweat. So rapid onset of these symptoms might be a clue. And in that case, we often will get a PET scan. So PET scan is really very good at helping us differentiate if the lymphoma patient has is slow growing or fast growing. So PET scan, in my mind, is kind of the next step that we consider, and maybe a biopsy as well, but a PET scan helps us figure that out, so that might be the next thing. And if you have a large cell lymphoma, the treatment strategy changes a little. So when we talk about Waldenstrom's, we don't have a cure yet. I am hopeful that will be in the near future, but we don't have a cure yet. So with Waldenstrom's, our focus is often on controlling symptoms and allowing patients to have a good quality of life without complications. But if you have a large cell lymphoma, our focus changes to actually curing the lymphoma. So you really need to get rid of that lymphoma completely. So we often then change to a plan to use more intensive chemotherapy. I've listed just a couple of the options there, like R-CHOP or Pola-R-CHP. So you use a very aggressive therapy with the hopes of curing that large cell lymphoma. Those therapies do help treat the Waldenstrom's, although, again, they don't cure the Waldenstrom's. That will still be there even if you cure the large cell lymphoma. But our strategy, like I said, is aggressive. We give chemotherapy, and sometimes it's followed by other treatments, like maybe a stem cell transplant or something else, depending on the course of the disease. So I think it's important to recognize that this happens. Again, very uncommon, but it does change our treatment strategy. And I think that's kind of the important part about amyloidosis or large cell lymphoma. It's important to pick those up so that we know if we need to do something differently. Another rare complication of Waldenstrom's is Bing-Neel syndrome. So Bing-Neel syndrome is when the cancer cells from the Waldenstrom's, instead of just being in the bone marrow or the spleen or lymph nodes, those cancer cells have found their way into the area around the brain or spinal cord. The cells might just be circulating in the fluid around the brain or the spine. They might attach to or build up in the lining that goes all the way around the brain and the spinal cord, or it might actually start to grow within the brain, like a more solid mass or something of that nature in the brain. So it can be a lot of different manifestations, but generally Bing-Neel syndrome, like Waldenstrom's, is a slow-growing process. So many patients have symptoms for months, and it's not picked up initially because it can be very subtle and can be slowly progressive. So it's just I wouldn't expect it to be aggressive. If there ever is like really rapid changes, and we'll talk about what symptoms come with the brain involvement, but if it's rapid changes, then we worry about something else, because it usually is slow onset. So Bing-Neel syndrome typically occurs at the time of disease relapse. So a patient might have Waldenstrom's for a long time, and then later on, at a time that their disease is relapsing, they develop Bing-Neel syndrome. Although that's the case most of the time, there are some times when the rest of the disease is stable, so the IgM is completely normal, but then Bing-Neel is developing in that setting. Or in rare cases, the Bing-Neel syndrome might be the initial presentation of Waldenstrom's. So I have a few patients like that no one even knew they had Waldenstrom's, and they presented with some neurologic symptoms and ultimately were diagnosed with Bing-Neel syndrome. That's very tricky, because I am sure if you went to the doctor and you had a new seizure, the first thing that they're thinking of is not Bing-Neel syndrome if you don't have Waldenstrom's. So often those patients go through quite a bit of testing and a long time before the accurate diagnosis is made. So this is a list of symptoms that can happen with Bing-Neel. It's not completely comprehensive. It's the main symptoms, and the top 3 that are bolded are the most common symptoms. So gait and balance issues, so trouble walking or balancing. Cranial nerve deficits. So your cranial nerves are the nerves that control kind of your face and your eye movements. So sometimes if you have cranial nerve deficits, like the eyes might not be moving appropriately, or you might have drooping in the face or something of that nature. Kind of stroke-like symptoms maybe. Or cognitive deficits, so significant changes in how you're thinking. I think this is always a little bit of a challenging one, to be honest, because we have a lot of patients that as we all get older, cognitive changes can occur. And so we always have to, I think, be cautious in how we interpret that as, is this a change that could develop just in general with aging, or is this something that we worry about with Bing-Neel syndrome? Other things that might happen are significant headaches, weakness, like if you have weakness in one arm or one leg or something like that. Psychiatric symptoms actually can happen. We've had patients that have, new sudden onset severe depression or something like that, which can sometimes be a sign. Seizures can happen, although uncommon. Impaired consciousness, so sometimes I've had patients, their family tells me that they're talking to their loved one and they're just completely zoned out. It's as if they're not even conscious anymore. And then hearing or vision changes. Again, just like I mentioned before with amyloidosis, these symptoms, just because you have them doesn't mean that you have Bing-Neel syndrome. They can have other causes. For example, gait or balance issues are classic things that can happen if you have peripheral neuropathy. So if your nerves are affected by Waldenstrom's, you might have trouble walking or balancing. And that doesn't mean necessarily you have Bing-Neel. So we have to, when these symptoms develop, we have to, I think, understand exactly from the patient what's happening and really try to tease out, are these things does it neatly fit in the box of what we expect with a typical peripheral neuropathy, or are there warning signs or symptoms that make us think something else could be going on? And the same thing, hyperviscosity. It can cause some changes in cognition, as I mentioned, like foggy thinking or lightheadedness. It can cause kind of some of these things, or vision changes. So again, not necessarily if these are present, does that mean you have Bing-Neel? It might be an indication of something else like hyperviscosity, or even a totally unrelated disorder that might not be from the Waldenstrom's, but just key things to think about. If we're worried that a patient has Bing-Neel syndrome, one of the first things we do is an MRI. And we typically get an MRI of the brain and the entire spine. And the reason we do that is because we want to look for those locations that I mentioned that the cancer cells can build up within the brain. So you can see in this picture here that the brain area, those white areas, that's abnormal. So sometimes the MRI will show us that it's built up in the brain. But also if you get a picture, an MRI of the whole brain and spine, you can see the lining around the entire brain and spine, and you can see, is that lining abnormal? In most cases, the brain MRI will be abnormal, but there are some cases where the brain MRI looks fine and the patient is still diagnosed with Bing-Neel. I didn't put this in the slide, but an important point to consider is we generally try to get the MRI before we move on to the next step, which is a lumbar puncture. So lumbar puncture is a procedure that's done to get some spinal fluid, to test that fluid from around the brain and spine. And if you do that before the MRI, it might show an abnormality in that location on the MRI, and then we don't know, is that abnormality because you just had a procedure there, or is it because of the disease? So we generally like to get the MRI first. But a lumbar puncture, kind of similar to an epidural that women have when they're delivering babies, is a small needle that goes in the middle of the back between the backbones, and we take some fluid out. And then we send that fluid for very detailed analysis to see, are there any cancer cells in there? And if the cancer cells are there, even if the MRI is negative, that can diagnose Bing-Neel syndrome. Most of the time, a brain and spine MRI and a lumbar puncture is sufficient to make a diagnosis. There are rare cases where a patient might need an actual biopsy from the brain. That is not common, I would say. In 5 years, I've seen a lot of Bing-Neel syndrome at Dana-Farber, and I have not seen that necessary yet, but it definitely can happen occasionally. And the treatment for Bing-Neel, luckily, treatment for Bing-Neel is one of our preferred therapy, is one of the easiest and nicest therapies that we use in Waldenstrom, zanubrutinib. That medication, zanubrutinib, and ibrutinib is what we used to use previously, crosses the blood-brain barrier, so it gets into that area around the brain and spinal cord and treats the disease very well. So most patients will do very well with zanubrutinib. And so that's our first choice recommendation in many cases. But there are other options. So we have chemotherapies, we have other pills. So we do have other options of what we can use as well to treat Bing-Neel syndrome. But patients generally, even with Bing-Neel syndrome, I think sometimes people get worried if this cancer is in my brain, is that, what does that mean for me? And generally patients with Bing-Neel syndrome do incredibly well. And we expect their disease around the brain and spinal cord to respond as we expect the rest of the disease to respond. So I'm going to transition now to talk for a few minutes, the last couple of minutes, about something called cryoglobulin and then cold agglutinin. So the complications of Waldenstrom's can sometimes be related to the cancer cells being in a different location or abnormal location, like if it builds up in the brain. So it might be a problem related to the actual cancer cell. Sometimes the complication can be related to the IgM or the antibody misfolding and building up somewhere. But these complications I'm going to talk about now are actually related to a property about the IgM that's activated in the cold. So I used Celsius here for the temperature, 37 degrees Celsius, which is equal to body temperature, 98.6 in Fahrenheit. But what cryoglobulin is when people have antibodies that precipitate or kind of form a gel or separate out from the blood at a temperature below body temperature. So typically, if you're exposed to cold temperatures, those antibodies will gel up. They'll connect with other proteins and kind of thicken the blood. And then when you warm back up, those generally unclump, and then they kind of go back to circulating in your system. There are different types of cryoglobulins. So we see them in Waldenstrom sometimes, but there are other diseases like hepatitis C or other rheumatologic disorders that can also have cryoglobulin. So it's not specific. It doesn't only occur with Waldenstrom's. It can happen with other conditions. And for lack of a better word, the term we often use in our group is that when we say when patients have cryoglobulin that their IgM is stickier. So it's more prone to clumping together. It's more prone to getting stuck in blood vessels and things like that. So this is just a picture to give you an idea of a sample from the same patient when they have cryoglobulins and when they don't. So in this picture, you can see on the left, the patient's sample when it's cold, so when it's below body temperature, if they have cryoglobulins, the blood or this sample of serum looks much thicker, so you can't even see through it. But if you take a patient that doesn't have cryoglobulin, so that would be on the right side, and you make the sample cold, it doesn't clump up or it doesn't gel up. So it just, you can imagine if this is trying to flow through your bloodstream and you have this clear, thin liquid, it's going to move a little bit better than that which is thicker and more like a gel. And this graph here is just to give you an idea, because I mentioned earlier when I was talking about hyperviscosity that patients with cryoglobulins are more at risk for having hyperviscosity at a lower IgM level. And that's what this graph is meant to show you. So the bottom line is a patient's viscosity that's measured at different temperatures when they don't have cryoglobulin. So that bottom line is a very, pretty flat line that if you measure the patient's viscosity, when it's at different temperatures, whether cold or warm, the viscosity is about the same. When you look at a patient, the other line that's going upward is a patient that has cryoglobulins. And if you look, the thickness of their blood is very dependent on the temperature. So as the temperature gets colder, so as you're moving down into the 20-something degrees, on the right side, you can see that their viscosity goes up tremendously. So the viscosity really can be affected by temperature if you have cryoglobulins. And so let's say each of these patients have an IgM of 4,000, and at a regular body temperature, neither one of them have symptoms of hyperviscosity, but then you put them both in a very cold environment, the patient with cryoglobulins might develop symptoms related to the fact that their blood is going to get thicker in that setting. So we at Dana-Farber, for new patients, we typically check cryoglobulins on everyone, not because we're necessarily going to change what we're doing at that moment, but we like to know what you might anticipate in the future. And we do find cryoglobulins in a percentage of our patients, maybe around 10% or so, but the majority of those patients have no symptoms because of the cryoglobulins. If we see it there, we know what to watch out for in the future, but it doesn't necessarily mean it's causing symptoms. But the symptoms it might cause, I put some pictures of it. So one is Raynaud's. So many patients know what that is because it can happen even in patients without Waldenstroms, where you don't get good blood flow into the small, blood vessels, either in the fingers. It can happen in the nose, it can happen in the ears, happen in the toes, where you don't get good blood flow and the digits can turn white. The other thing that can happen is you can get what's called acrocyanosis, which is the second picture, where the digits actually turn blue. And again, you can see that in the nose or ears happening as well. The third picture is something called purpura. So it's just these initially tiny red dots that kind of coalesce into these larger red spots. And that can be a sign of cryoglobulins. Often patients will hear the term like cryoglobulinemic vasculitis. So I've had a few patients that for years had a rash like that on their legs. They saw their doctor, they were told they had vasculitis, and that was it. And then ultimately it turns out that the cause for that was their Waldenstroms. And then sometimes on the lower extremity, like at the lower legs in particular, patients can develop skin ulcers that don't heal. So sometimes I'll have patients present and they'll say, yeah, I've had this, small wounds, these ulcers on my legs, they've been there for months and no one knows why they're not healing. So that might be a symptom. The other thing that I have listed, so cold sensitivity, sometimes it can cause joint discomfort, sometimes kidney issues, sometimes cryoglobulins can cause neuropathy. So depending on the type of cryoglobulin you have, the levels, how easily it's activated, there can be different symptoms. But just the presence of the cryoglobulin itself does not mean that you need to have treatment. It's really if there are problems or symptoms related to that we treat the cryoglobulins. I would say that, again, similar to when amyloid is a problem, the treatment for cryoglobulin is to get rid of that antibody that's causing the problem. So you treat the underlying Waldenstroms, the antibody levels drop, and typically the symptoms will improve. So this is a disorder that's somewhat related, called cold agglutinin syndrome. Again, something that we check in all of our patients that come to Dana-Farber, so we know if patients are at risk for this, but it happens in the single-digit percentages of patients with Waldenstroms. If it's not causing symptoms, again, we monitor. But what cold agglutinin is the antibodies in the patient's system is attracted to the red blood cells. So it's an anti-red blood cell antibody. So instead of being, our antibodies generally should be attacking germs or bacteria or that sort of thing, but these antibodies are attacking the red blood cells, and they're activated to do that in the cold. This is one of the types of autoimmune anemias that happen with Waldenstrom's. So there are different ways that the body can destroy its red blood cells in Waldenstrom's, and this is just one of them. But the picture here shows you what the blood would look like under the microscope, and then in the figure that was drawn, what it would look like in normal conditions. So the top portion of that picture is a microscope of a patient with Waldenstrom's that doesn't have cold agglutinin, or a healthy patient. You would see these individual, the tiny little dots are the red blood cells. They would be individual, kind of spread out across the slide under the microscope. And that's what it shows in the pictures. The patient has these individual red blood cells. They have antibodies in there too, but the antibodies are not stuck to the red blood cells. But when you have cold agglutinin, when you're in the cold, this is what happens in that second half of the picture. So under the microscope, what we see now is that the red blood cells are not all individual anymore. They're clumped together. And in the picture below kind of explains why, because those antibodies in the cold are activated to kind of hook on to all the red blood cells. So then all the red blood cells are clumped together. And you can imagine if all of your red blood cells are clumping together, it makes it hard to flow through the blood vessels. Patients can have issues with the blood flowing to small blood vessels. And then the other thing, once these antibodies bind to red blood cells, the body thinks, oh, there's something wrong with these blood cells, the antibodies hooked onto it, we should destroy them. So then patients have a drop in their red blood cell levels, and that's called hemolysis, because the body destroys those red blood cells, and patients develop anemia. So hemolysis, or breakdown of those red blood cells, it can occur with cold agglutinin. And this underlying syndrome can flare when people are in the cold. So we typically, if patients have this, tell them to avoid cold when they can, like dress warmly, wear gloves outside if it's cold, that sort of thing. But it can also flare in the setting of infection. So some patients will present to me, their anemia is worse, and they just had a cold last week. And so that can make it a little bit worse temporarily. But some of the symptoms that might happen if you have cold agglutinin syndrome, two of them, as you see, are the same pictures I had on the cryoglobulin slide. So patients have the same problem. They have trouble with the blood flowing out to those small, colder areas of the body because of the clumping of the antibodies on the red cells. But the other thing is this particular rash. It's called livedo reticularis. It's kind of this lacy-looking rash where you have some areas of redder skin and some pale areas in the middle. And so that can be a sign of cold agglutinin syndrome. So again, treatment for cold agglutinin syndrome, just like cryoglobulin, is to treat the underlying Waldenstrom's. Typically, that will improve symptoms. If the symptoms are mild, I have some patients, they say, I have to dress more warmly, and if I wear gloves, I'm fine. But if I don't, I have symptoms. That's okay. But I have other patients who can't even take things out of their refrigerator at home, or they can't hold a piece of fruit from the fridge, or they can't go in the grocery store because the cold makes it unbearable. So in that setting, we can treat. Usually treating the underlying Waldenstrom's will get rid of symptoms, but in some cases, patients might need an additional therapy, such as one called sutimlimab. And what that drug does is block the antibody from attaching to the red cells. So if they need that additional extra help with that drug, we'll often use it. So, and these are just two notes that for these two disorders that I think are important to keep in mind. If you have cold agglutinins and cryoglobulins, it is best, if you can, to have your blood drawn and kept warm before it gets to the laboratory. It's not always possible, I know, but if possible, that's a good thing to do because you can get more accurate lab results if the blood is drawn, kept on a warm pack, so that this clumping together does not happen while it's in the test tube. If the clumping happens, like for example, with cold agglutinins, you might not actually accurately be able to measure the amount of red blood cells or the hemoglobin. Or with cryoglobulins, if all the IgM is clumped together, you're actually not going to get an accurate IgM level. So if you can keep it warm, that's important. And for patients who have really significant symptoms from either of these, we often will use blood warmers if they're having pheresis or a blood transfusion so that they're not getting a cold product into their body, that the blood is warmed before we transfuse it. So those are just some key things to keep in mind if you're someone who suffers with cold agglutinin or cryoglobulinemia. So this is not necessarily a complication of Waldenstrom's itself, but maybe a complication that can come up with treatment that I think patients should be aware of. And that's an IgM flare. And that can occur when patients get an initial dose of rituximab. So when you get rituximab, it can make the IgM go up initially. That risk is much higher if you get rituximab by itself, but it can happen even if you give rituximab, for example, with bendamustine. And so I think that's really important to keep in mind. One, if you have a high IgM already, let's say your IgM is 4,000, 5,000, 6,000. If you get rituximab, that IgM can go up by a couple of thousand, and even if you didn't have symptoms from hyperviscosity before, you might develop them now. So the general rule is if the IgM is above 4,000, we don't give rituximab. We hold off. The other case is if you have really significant symptoms from cold agglutinin or cryoglobulins. We have seen it, unfortunately, that patients will have poor blood flow to their fingers or these ulcers on their legs or poor blood flow to the nose, and they're given rituximab, and the IgM goes up and causes more problems, and it exacerbates the underlying issue. Patients can completely lose blood flow to the digits or have worsening ulcers on the extremities. So really important if you have a high IgM or you have bad symptoms that are related to the IgM itself, that the preference is to give the other therapy, like maybe just give the bendamustine on its own and add rituximab later, or maybe do pheresis before giving rituximab. But I think it's just something to keep in the back of your mind. So essentially, I just went through a lot of different complications that can happen with Waldenstrom's. This was not an extensive list, but hoping to just introduce some concepts so that you all can be aware of what might happen. And again, I didn't want this to be kind of a scary lecture saying all the things that could go wrong, but I do want to say that luckily we have so many incredible therapies for Waldenstrom's, so many more in development, that even if these complications occur, I think we have therapies that can take care of these. And so it's a really, I think, positive message to come away with, that even though these complications happen, we have excellent things to take care of them. So thank you all for your attention.